Hello and welcome to the next instalment of the Langford Academy's recent graduate programme. Today we're going to talk about how to manage a GDV. Please do subscribe to our channel and you'll make sure you're always the first to know about any updates of new videos that we're uploading. So as I said, we're going to talk about how to manage a GDV today. We're initially going to cover the initial preoperative stabilisation, talk about different ways to decompress the stomach, and then in the next video we're going to talk about how to operate on these animals and when's the best timing of the surgery. So the case we're going to discuss today is a 4-year-old male entire labradoodle. He's 40 kilograms and he's got a very acute onset history of unproductive retching and abdominal distension. And as soon as you get this phone call, you can already kind of guess the diagnosis is likely to be either a gastric dilation or a gastric dilation with volvulus. On examination, the dog is in circulatory collapse, so he's tachycardic, he's got quite weak peripheral pulses. He's also hypersalivating and he's a little bit tachypnic, so his respiratory rate was around 45 to 50, depending on when you measured it. So hopefully, as I say, you would all sort of recognise what this diagnosis might be and therefore tailor your investigation into that. But I think before we get to that stage, it is really important to stabilise these dogs adequately because ultimately it's likely to be the circulatory collapse that could kill the animal rather than the underlying pathology that's going on. So this is him when he presented, and hopefully it shows well enough on this picture that you can see just behind his costal arch you've got this big swelling. It's very tympanic, you know, if you tap it, it sounds like it's echoey inside, and straight away we know this is likely to be either a gastric dilation or a GDV, as we've discussed already. So how are we going to stabilise this dog? The first thing is to try and get IV access, and remember that for these dogs, because the stomach is likely to be really dilated and pressing on the vena cava, their venous return from their hind limbs is likely to be particularly poor. So typically we place IV cannulas in both front legs and quite wide ones. So in this size dog I'd definitely be going for a green one if you can get it in, and ideally one in both legs. At the time that we place these, it's worth getting just a little bit of blood if you can for a blood gas analysis. I appreciate not everyone will have this available, but if you do, this is one of the cases where it's really useful just to get a baseline as to how these dogs are doing, and also potentially there's some prognostic value of measuring some things. So the one we particularly are interested in is the lactate, and there's been a few studies looking at this and how valuable it is. So initially the sort of suggestion was if the lactate's really high, that's a bad thing. More recently they're now saying that it's how quickly the lactate comes down with fluid resuscitation. So if the lactate is high and it comes down more than sort of 40% of the original value, that's quite a good prognostic sign. Whereas if it's quite slow to come down or it persists at a high level despite fluid resuscitation, then that's something that's a bit more worrying. So it wouldn't really change how we manage these dogs, but potentially it would change how you speak to the owner and the sort of prognosis that you're giving them, although we would, you know, obviously still treat these animals. In terms of fluid therapy, these animals will be hypovolemic, they will be in shock, and so they do need fluid boluses. So typically we'd be giving around 20 ml per kilo initially, and we'd give that as a bolus. So in a 40 kilo dog, obviously you're talking about 800 ml of fluid. So probably in this case I would just hang a litre bag, put the pressure bag on it and just squeeze it in as quickly as I can into a front leg. If that wasn't enough, you know, you can safely give up to sort of 60 to 90 ml per kilo. So potentially for this dog, that means you can give up to sort of at least 3 bags, maybe even 4 litre bags if you need to. So I'd sort of be thinking about number of bags rather than number of mils, and definitely it's one to squeeze in as quick as you can rather than to put it up on the fluid pump and set it as 999. You know, we want to get this fluid in as quick as we can, get that heart rate down and try and restore perfusion as much as we can. So at this point you've got your blood gas, hopefully, if you've got that available, you've stabilised the animal to some extent, you know, got the heart rate down and so on, you've got your IV access. So now we need to think about how to manage these going forward. And at this point, really, what we need to do is cement the diagnosis. So we need to know, is this definitely a GDV or is it just a gastric dilation? Because that will affect how we manage this dog, how quickly we try and progress it to surgery and so on. So to do this, you do just need a single abdominal radiograph, so a right lateral radiograph, and it's really important that it's a right lateral because otherwise the signs will look a little bit different. So you can see the dog's radiograph on the image now. So the thing that we're really looking for is you've got this double compartment. So you can see that the body of the stomach is that sort of large black gas-filled structure. And then the pylorus, which should normally be sort of fairly ventral, you can see how that's squished up, and that's what makes this kind of double compartment sign. And so you've got this shelf in the middle that's just highlighted in yellow there. And this is kind of the typical appearance that you would see for a GDV. So if you're doing a right lateral radiograph and you can see the body of the stomach, the pylorus separately squished up to the top with this shelf, that's really the pathognomonic sign for a GDV. And we know that this one has TORS, and therefore surgery will be appropriate. If it's just a gastric dilation, it will just be a single gas-filled viscous, so you won't get that shelf in there. And with those ones, they likely will still need some decompression, and we would usually recommend gastropexy at some point, but it wouldn't be something that you'd have to rush into. You know, we decompress the stomach, stabilise them overnight, potentially operate the following day or a little bit later in the week. It wouldn't need to be something you rush into, but they will need surgery at some point just because they're at such risk of developing a GDV in the future. This is another example of a different case, and the reason to show this one is that you can hopefully spot along the ventral border here where the arrows are that there's kind of an extra gas line within the stomach wall. And this is what happens when we get gastric necrosis. So sometimes when we get gastric necrosis, particularly as it progresses, gas will start to be present in the gastric wall, and so that's a sign that this dog again will need surgery and likely will require some sort of gastric resection. So just something to be aware of. Once we've done that, you know, we've got the diagnosis now, we've got the animal, the stabilisation process started, we now need to think about how we're going to progress this case. This is when we start to think about the sort of secondary interventions. So at some point we're going to need to decompress this stomach, and that's really key to trying to stabilise these animals. To do that, we're likely to need some sedation. Now, it might be enough just to give some opioids, and so you could, for example, just try giving an opioid, either methadone or butorphanol, although you just obviously have to be a little bit careful if you're going to give butorphanol that we're going to need to anaesthetise these animals later. For surgery, we'll need to make sure we can analgese them appropriately. So typically a pure mu opioid if you can, so something like methadone, and they may need a little bit of sedation on top of that, depending on how they present. So sometimes they're really flat and we don't need to, and that was the case for the one that we showed you already, but sometimes they will need a little bit of sedation as well. It's worth having an ECG connected, so we know that these dogs are prone to getting premature ventricular contractions. If we're just seeing those in isolation and they're not affecting the dog's cardiovascular status, we wouldn't usually treat those. It would just be something to be aware of. But we would treat them if it was either causing issues with the blood pressure, so we were getting a lot of pulse deficits and we feel we need to try and get better pulses, we might start a lidocaine CRI. The other indication would be something like if we've got RNT phenomenon, so it's going from one straight into another one, because those dogs are at risk of going into ventricular tachycardia. And the last indication for me is if they're multiform, so we're getting lots of different shapes of VPCs. Again, those dogs are at risk of going into sort of VFib and things, so that might be another indication to treat those. And then lastly, I would be considering antibiotics for these cases. You know, there's a big risk of gastric wall necrosis, and that could cause bacterial translocation into the bloodstream. And so if you are going to be doing surgery, it's a good idea to get antibiotics on board at this point. Here in the UK, we typically use cefuroxime at 20 mg per kg IV, but another alternative would be to use amoxiclav IV as well, 20 mg per kg. Just watch, obviously, that we can see some hypersensitivity reactions with that. So hopefully these dogs are now a little bit more stable, but really to properly stabilise them, we do need to decompress this stomach. And for those of you that managed to do this successfully before, you often do notice a massive improvement in the cardiovascular status as soon as you decompress them. So for me, I'd always try and do an orogastric intubation, so to pass a stomach tube all the way from the mouth into the stomach, because if we can do that, we can get quite a wide bore tube down there. We can make sure that we properly suction out all the fluid and gas, potentially some food if there's bits of food in there as well. The other alternative which we'll come on to is to do a gastrocentesis, so just to drain the stomach through the body wall. That's not usually quite as successful, and obviously we're then worried about things like the stomach leaking and so on. So if you can pass a stomach tube, that would be my preference. To do that, I'd normally put a roll of vet wrap or bandage material in the dog's mouth, so just have quite a long roll in tubular shape sticking out of the mouth, and that just means that they're not going to be biting down on the stomach tube as you're passing it. So if they won't tolerate that, that would be the time when you need to reach for some sedation. But if they will tolerate orogastric intubation conscious, that would be great as well. So we're just going to lube up a stomach tube, pass it down, and it usually goes fairly easily at the start, but it does get a little bit stuck when you're trying to go through the diaphragm. And at that point, if you just gently twist the tube in a clockwise direction, that will often help the passage of the stomach tube down into the stomach. And so you do have to put a little bit of pressure on it to pass it down, so don't be afraid to push a little bit. Obviously we want to be careful that we're not pushing it hard through a stomach wall, for example, if we've got gastric necrosis. But trying to get it through the diaphragm, you do need to push a little bit and give it a little bit of a twist as well to pass through there. And usually before we pass it, we usually try and pre-measure the tube. So you want to pass it roughly to the level of the 11th rib. So pre-measure the tube, put a little mark with a pen on the tube so you know how far to put it in. And then it should be fairly obvious once you pass through the diaphragm, because often for these you will get a sudden release of gas from the stomach, and the dogs, let's say, usually will improve clinically quite quickly. So it's quite satisfying if you are able to do this. If you're struggling and you can't do that, the other alternative, as I said before, is to do a gastrocentesis, so percutaneous gastrocentesis. So to do this, we're going to clip a little patch of fur on the right side of the dog, just behind the last rib. I would usually then try and use a point of care ultrasound scanner just to make sure the spleen's not in the way, and that we've got sort of clear access to the stomach. So it should be fairly obvious if it's full of gas, because you'll get that distal acoustic shadowing on your ultrasound. So scan a little patch just behind the rib, check that you've got a clear path straight to the stomach, and then you do want like a really big gauge IV cannula or even a needle just to pass straight through into the stomach. And again, in this situation, you should get that sudden release of gas that you'll get when you pass your stomach tube. It's just likely not to decompress quite as much, because either the stomach will drop away from the body wall and you'll lose your access, or you might get bits of food or fluid blocking your tube. So do use a syringe as well to suction on it if you need to, but as I say, it's definitely going to help the animal. It's worth doing, but it's probably not quite as good as doing the orogastric intubation if that's something that you're able to achieve. So once you've done this, as I say, the dog's heart rate should drop down really nicely, blood pressure should come up, hopefully your lactate's going to improve if you repeat your blood gas, and overall the dogs just look a lot better, so they'll start to be a bit more mobile, a bit more conscious once you've done this. So at this point then, really, we've got our GDV, we know that this dog is going to need surgery, but when should we operate? Do you need to go straight into surgery, or do you wait till everyone's available the following day? And also, what do you need to do when you go in there? So each case will be slightly different, and we'll talk through that in the next video. So please do look out for the release of the next video and join us at that point, and make sure you subscribe to our channel. Thank you.